remain speaker. I extend on behalf of the Tanzanian Alliance, extend my gratitude to the participants, research and advocate the contributing to support. Your dedication strengthens our movement, by future projects. Let us use this index as a tool for accountability, advocacy, and tech. Together, we can ensure that Tanzania is part of the reality of progressive field, not one. And now, officially welcome all of you and the application that we work in today.
Hello, hello.
Again.
Hello. Hello. Can you hear me? It's working. Ladies and gentlemen, yeah. Okay, we have a number of speakers covering ranges from the globe in Africa, then we trickle down to Tanzania. We'll be receiving presentations addressing mostly various issues related to tobacco use. And actually the talks are addressing cardiovascular and respiratory affliction. To start with, I'm going to call upon Mera Asunta, who is outside Tanzania and Africa, but she's an international tobacco control advocate with more than 30 years of experience in policy development, and she's the head of research and advocacy at the Global Center for Good Governance in Tobacco Control. Mary is also the lead author of the Global Tobacco Industry Interference Index. She is also a senior policy advisor to the Southeast Asia Tobacco Control Alliance. In addition to that, I think Mary has always been with us whenever we are launching the Tanzania Index, and we thank her very much for that endurance and continued support. I don't know what time is it, Mary, you will tell us, but I'm sure it might be too late or too early for you. You need to present and maybe go to bed, whatever you will tell us. So, Mary, thank you for your continued support. And with these few bio-sketch remarks, I would like to invite you to talk to the Tanzanian audience seated in here and those who are outside or within Tanzania but are online. Please, Mary, if you are listening or you can hear me, the floor is open for you. Mary? Is she connected?
Hello, can you hear me?
Okay, Mary, we can hear you. Please go ahead. Did you hear me when I was introducing you?
No, I'm fine. I can hear you. Thank you so much, Honorable
Okay, you're
Moderator,
welcome.
distinguished speakers, Madam Lutgard Kagaruki, dear participants. Today, I am located in Kuala Lumpur, Malaysia, and I join you at a very reasonable hour, and that's great. On behalf of the Global Center for Good Governance in Tobacco Control, I want to thank the Tanzania Tobacco Control Forum for this opportunity to present the launch of Tanzania's Tobacco Industry Interference Index. On how public health is being protected in Tanzania and the gaps that must be addressed. I will be providing a few key findings of the Global Tobacco Industry Interference Index. And I want to thank the Tanzania Tobacco Control Forum and all the other 99 collaborators from 100 countries who contributed towards the development of this global index, including 20 countries from Africa. I would like to ask the technical person to allow me to share slides, please.
We can't see what you are talking about on the screen.
Okay, can you see now?
Huh? Are you projecting?
Okay. Is that better?
Okay, now we are with you.
Great, thank you so much.
Okay.
This index is a civil society report, or you can refer to it as a report card, because it makes an assessment of how well countries are doing in implementing the WHO Framework Convention on Tobacco Control, Article 5.3 guidelines, which were adopted by all the parties 17 years ago. I will now provide the key findings of the 2025 Global Tobacco Industry Interference Index. And there is both good news and bad news. And I will begin with the bad news first and end on a positive note with the good news. So the good news is that the smoking prevalence of Tanzania is still in single digit. So many countries in Asia, for example, in Latin America and even in Europe, are all striving to bring their smoking prevalence down to single digit. And in Tanzania, it is among males, it's 7%. I think we can get more accurate figures later. But the point is that it is relatively low compared to many other countries. And the tobacco industry is therefore using this as an opportunity to increase its market share. So what we have found is that across the globe, as you can see in this global map, no country has been spared from tobacco industry interference. And the way to interpret this map is that the lighter colors, that's the yellow and the light green, means that there is a lower level of interference, and the the deep red, the browns, the maroons, the purples, a color indicate that there is a much higher level of interference, particularly the maroon and brown colors. So you can see that Botswana is actually doing relatively well in Africa, but at the other end of the spectrum, you've got Malawi. So you'll be hearing later today on where Tanzania is. Now, the other news is that the tobacco industry has been found to be more aggressive in the way it has exploited policy loopholes. It has dissuaded government policymakers and officials. It has enticed and frustrated governments across the globe in their efforts to protect public health. And this is a pattern that we have seen, which must be addressed. So you may be curious to know where is Tanzania's ranking out of the 100 countries that we surveyed. And Tanzania is towards the bottom, 89th out of 100 countries. And that's not a good position to be in at all. In fact, Tanzania is deteriorating. And across Africa, 20 countries participated in the survey, and Tanzania is 18th out of the 20 countries in Africa. There again, towards the bottom three, and you will hear more about this. So therefore, the question to ask is, how is Tanzania responding to tobacco industry interference, which, as you can see, is at an all-time high? And how are the government officials protecting and implementing tobacco control? Because Tanzania is a party to the WHO FCTC. So that's the question really to ask. So I want to present some of the main key findings. We know that the tobacco industry should not be allowed to participate in policy development. And we found the good news is 18 countries across the globe have strengthened their protection of the policies by adopting or enforcing Article 5.3. And this includes several countries in Africa. But on the other hand, the bad news is that more than 60 countries were found to have been influenced by the industry in manners such as they failed to raise taxes, they delayed increases of taxes, or in some instances, they even lowered tobacco tax, particularly on new tobacco products such as heated tobacco products, or they granted exemptions, to the tobacco industry. And one area that I will pull out is that the tobacco industry pressured countries that had to embrace e-cigarettes, nicotine devices, pouches, flavored new nicotine products. So the industry, as you can see, as countries implement the WHO FCTC, the industry is introducing new products in the market. It does not want governments to ban this product. And mind you, they all have got nicotine in them to keep users addicted, because nicotine is addictive. And in countries, some countries where governments have actually banned these products, and there are about 46 countries across the globe that have done this, the tobacco and nicotine industry have tried to revoke the bans, and they've gone to the court, as they did in Panama, or they tried to weaken the regulations, as they did in the Philippines. In the Philippines, they lowered the consumption age from 21 years to 18 years. And they have opposed and delayed tax increases of these products, and they have lobbied policymakers to pass laws that are favorable to the industry. But the good news, as I've mentioned, is that 46 governments have pushed back on the industry pressure, and they have banned e-cigarettes and heated tobacco products, including 5 countries in Africa: Cabo Verde, Ethiopia, Gambia, Mauritius, and Uganda. And that's really a good thing. It should provide some inspiration for us to know that in order for governments to take action, you do not have to, be in a high-income country. But Tanzania has not banned these products yet, and they will start to flood the market as the government prepares to strengthen tobacco control measures. And by design, they target children in the, in introducing flavors that are popular with very young, children as well as teens, and also the device, the design of the device itself. It is designed in a manner that it can be held very easily in the hands of children and minors. One bad news is that Philip Morris International has re-entered Tanzania. They had exited Tanzania some years ago, but they have now entered Tanzania, and this is not a good sign for tobacco control at all. They have assured the government that they will buy local tobacco leaves, which means Tanzania is on reverse now to increase leaf production. But we have to ask, in return, what benefits have been assured to this particular company to welcome it back into Tanzania? The tobacco industry and nicotine industry have also started conduct CSR activities, that is corporate social responsibility activities. And the good news is that about 74 countries in the world have actually banned such activities because they're a form of promotion or sponsorship. And in the 100 countries that did the survey, 32 of the countries have banned tobacco-related CSR activities, and 5 countries did not accept any contribution, from the industry. And what did the industry do across many countries? They targeted the non-health agencies or departments with their charity. They latched on to government priorities and appealed to willing ministers and parliamentarians to accept their charity. So what happens when a government accepts charity from the industry is that the government then compromises its role as a regulator of the industry. Another requirement in Article 5.3 is unnecessary interaction with the tobacco industry is not allowed. So Article 5.3 says very clearly in the guidelines, governments should interact with the tobacco industry only when strictly necessary to effectively regulate the industry and tobacco products. Only to strictly regulate the industry. That's when governments should interact with the industry. And unnecessary interactions occurred when high-level government officials met with the industry to foster relations, made agreements to collaborate, cut ribbons, hand out checks, or hand out scholarships to poor children in farming communities. All of that is considered unnecessary interaction. So some examples from across the globe, we found that members of parliament, ministers, and governors of municipalities actually accepted sponsored study visits to tobacco company facilities. And the industry has got these facilities, in some high income countries, which are, popular tourist destinations like Switzerland and Italy, for example. And so some of the industry targeted high-ranking officials on study visits. And we found that at least 19 governments across the globe collaborated with the tobacco industry, and they did this through signing memorandum of understanding. The industry conducted sessions, training sessions, or enforcement activities to tackle smuggling. For example, giving a machine that destroys smuggled cigarettes. So when governments do their raids, and they confiscate all these illegal cigarettes, the industry comes along and gives them the machine to actually destroy. That is an example of CSR, and that is also unnecessary interaction which should be banned. Transparency in interaction with the tobacco industry reduces interference. So the Article 5.3 guidelines calls for transparency. It doesn't say do not meet with the industry. Remember earlier on I said that government officials can meet with the industry provided they are to regulate it when strictly necessary to regulate it to control tobacco products. And when they do interact with the industry, they're supposed to make the interaction transparent. In other words, no closed door meetings, in offices or even in hotels. Now, one way some of the countries have actually started taking steps towards transparency is, to put in place good governance measures. So we found that 14 countries have got lobbying laws. That is, they have a general register for lobbyists, which is accessible to the public. And we find that many of them are high-income countries in the West, but there are a few countries also from Latin America, such as Panama, Mexico, that actually have got these registries. They're really very good because sometimes government officials don't know really who is representing the tobacco industry. So having these registers is really a start in the right direction towards transparency and good governance. And our survey found that none of the countries in Africa have got a lobbyist register. So this is not exclusively just for the tobacco and nicotine industry. It is generally a registry for all corporations because, corporations want to influence and interfere in a government policy. So now for some good news. The Article 5.3 guidelines also calls on governments, on parties to avoid situations of conflict of interest. Regulators, policymakers should not find themselves conflicted when they are taking public health measures and protecting public health. They shouldn't. They should be made free to act in the best interests of public health and carry out their mandate to fully protect the public. So in the example, one of the things that the governments can do is to put in place an exit policy in employment. So there have been many cases around the world where we found that when senior government officials retire from the government or they leave the government, they get headhunted and picked to become consultants to the tobacco industry. And in some cases, it has also been the reverse. They come from the industry and then join the government as consultants. And so there is this revolving door between the government, and the private sector, particularly the tobacco industry. So both Uganda and Kenya have actually put in place an exit policy. So that the officials in Uganda, public officials, have to wait for at least 2 years after they leave government before they want, if they choose to join the tobacco industry, there's a cooling off period of 2 years. And in Kenya, the officials have to wait at least 3 years after leaving public service, should they want to work for the tobacco industry. And this way, it actually reduces the situation of conflict of interest and revolving doors. More good news in terms of what countries have done in implementing Article 5.3. So on the left, you can see that at least here I've given examples of 5 countries who have actually included components of Article 5.3 into their Tobacco Control Act. So Botswana, Uganda, Kenya, Ethiopia, and Gabon, which is not listed here, but Gabon has also done that. So in their tobacco control law, you find that this issue of conflict of interest, transparency, all of that is actually, and also rejecting contributions from the industry. In Botswana, those officials who are standing for public office cannot accept any political contribution from the tobacco industry. So, these are good practices and in good governance, which some of the African countries have actually adopted. And they did that, quite a number of years ago. In other countries, if it is hard to go to parliament to get these laws and also these measures adopted, the other thing that governments have done, and I've listed 10 governments here, is that they have developed circulars or directives or a code of conduct on Article 5.3, where it applies to all public officials. So Australia, for example, has got a code of conduct where any public official then, cannot interact with the tobacco industry just like that. No conflict of interest, no, what do you call it, accepting of charity, etc., etc. So, but it is a code, it's not law. And other governments that have also done that, particularly in Asia and elsewhere in Europe, as you can see. So what is the difference between the two ways of protecting public health? If you want to go to parliament, it might take longer. I mean, in the case of Tanzania, you have been waiting to strengthen your tobacco control legislation that's taken ages just to make your tobacco control legislation compliant with the WHO FCTC. In a situation like this, you might want to, like for example, the Ministry of Health adopt a circular. It should start with the Ministry of Health so that you are setting an example. And a very simple thing you can do is anytime that any public health official wants to meet with the industry or the industry has asked to meet with them, usually that is the case, you put up on your website that on this day at this time, this particular company is having a meeting with the Ministry of Health on what issue. That's it. It's as simple as that, which is like the first step towards transparency and also good governance. And Uganda, of course, has got Article 5.3 component, a really comprehensive component integrated into their tobacco control legislation, Tobacco Control Act of 2015. So they passed this act 10 years ago. And recently, on the 15th of March, the Uganda Ministry of Health, or rather the Uganda National Tobacco Control Committee, signed a no conflict of interest declaration aiming at safeguarding public health policies from interference by the tobacco industry. And this is really, really a very good measure, to be adopted. And it is in Section 25 of their Tobacco Control Act. And there are a few more measures that Uganda needs to implement. Kenya has got good transparency measures in place for interacting with the tobacco industry, and this is part of their Tobacco Control Regulation of 2014, Part 5, which says that any interaction between public authorities or officials shall be limited to that strictly necessary for effective tobacco control and enforcement. So this is exactly from the guidelines. And also, if an individual has got shares or interest in a tobacco business or nicotine business, when they join the government, they need to divest so that they remove the conflict of interest. And that's really a good, measure to adopt. So Kenya's next step would be to actually adopt a code of conduct that applies to all public officials and not just the committee that develops tobacco control. Nigeria did a very interesting, they took action in 2023, which caught the attention of the world. So this is not the Ministry of Health. This action is not taken by the committee or the unit responsible for tobacco control. This action was taken by the Federal Competition and Consumer Protection Commission. They found that BAT, British American Tobacco, had engaged in anti-competitive conduct and violations of prevailing tobacco control health measures, and they fined BAT US $110 million in 2023. And BAT paid the fine because they had been exposed for wrongdoing. So this is a really good move on the part of a non-health agency or department in the government that actually acts to protect public health and implement the WHO FCTC. So this really caught the attention of the world because very, very few non-health departments actually act in the public interest. They are usually, I think, acting on behalf of the tobacco industry, usually departments of agriculture, trade, finance, commerce, and the customs department. But what this does, by taking this action by the commission, they held the industry liable, and this contributed towards denormalizing the tobacco industry. I'd like to conclude by saying that the governments must implement Article 5.3, and they need to act cohesively as a whole of government to curb industry interference. They need to denormalize the tobacco industry related CSR or charities, or completely ban them, stop giving incentives to the tobacco industry, require greater transparency for increased accountability, and government officials must not find themselves in situations of conflict of interest. So just the last slide, that if you visit the GGTC website, you will find more materials which we hope will be helpful to you. With that, I'd like to conclude my presentation today, and I hand you back to the honorable moderator. Thank you, sir, so much. Thank you for giving me this opportunity to join you today. It is truly has been an honor, and it's my privilege. And I will stay on to answer some questions. Thank you so much.
Thank you, Mary, for that nice presentation, giving a clear, critical analysis of what is going on globally and dribbling down to Tanzania. Your last slide is actually something we should take seriously when we are deliberating on the way forward from here. You've given good examples where we are failing as Tanzania, and no wonder in rating we are in the worst situation. But the question is, this situation has been the situation over and over above. You give these action plans, but still we are at the same stage, if not worsening. Now, in our discussion, we should try and dig deeper on what action should we take to change the situation. Mary should not be coming to address and we find, oh, Tanzania is deteriorating. Until when? I'm surprised we might end up being out of 100, we take the 100 position. That is no good. Thank you, Mary. And I think the audience has taken note of the action plan, and will take that into perspective of our discussion. I hope you will join us for the discussion, if it is not too late for you.
I intend to.
Thank you for that.
No, it isn't. Yeah, I will stay back for the discussion. Thank you so much.
Okay, you're welcome. Okay. She's gone. Okay. The next speaker is going to address similar to what Mary has just given. I think now we narrow down to Africa region, and we will hear from Mr. Mohe, who is a public health professional with over 25 years experience, specializing in tobacco control. He's a former World Health Organization staff member. He has led major regional initiatives across Africa, including serving as executive director of the African Tobacco Control Alliance, ATCA, and he has contributed to key reports, supported the adoption of evidence-based tobacco control policies, and he continues to provide technical expertise, consultancies, and global training. So, like last time, Mr. Mohe presented the African situation, and we invite him to present the African situation again and tell us where Tanzania falls as of now. Mary has taken us where we fall globally. Let's hear from Mohe where we are in the Africa region. Mr. Mohe, are you with us?
Can you hear me, sir?
Okay, you are welcome to give your presentation.
Okay, so ladies and gentlemen, thank you very much. Good morning, good afternoon, and thank you, Mr. the Moderator, for giving me the opportunity to address the Assembly today on the Tobacco Industry Interference Index of Africa for 225. I'm speaking from Mauritius on behalf of the African Tobacco Control Alliance, which is a network of civil society organizations in we are present in 39 countries with over 100 CSO membership. So it's my pleasure to participate in this launch of the Tanzania Index. And my first slide, please. It's the Africa Index covers 20 countries. Is it okay? Can you see my
The
slide?
slide is not on the screen, Mohe.
Yeah, I share it with the team so that they can show it.
Okay, they are trying to project.
Okay.
Oh. But so how they stitch together.
That's good. Okay, next slide, please. That's good. Okay, yes, that was good.
Slides are up, Mohe.
It's okay. No, let's go to
Yeah.
the first slide.
Who is projecting? He wants the first slide.
No, the first slide.
Is it the first slide?
Okay, now move to the second one.
Second.
No.
Okay.
Okay, that's good. No.
We have different slides from you.
Okay, this is a one. This is a one.
That's the second one you requested.
That's it. That's it. This is good. This is good.
Moy,
Yes, I'm here. Okay, that's good. It's good.
is this not the slide you requested for?
No, you're just moving. The slides are just moving.
No, it just stayed on the screen.
This is the one. Okay. May I just continue?
Yeah, please do.
Okay, please, because I can't see. This is a slide. Okay. So the tobacco, the Africa index, it covers 20 countries. There are 12 Anglophone countries and 8 Francophone countries. And I believe that the index is quite representative of what is happening in Africa with regard to tobacco industry interference in tobacco control. And what the index does is to see how governments in these 20 African countries are protecting public health policies from the tobacco industry interference. We have to keep in mind that all these 20 countries have already signed, ratified the Framework Convention on Tobacco Control, and as such, they are bound to the FCTC, to the WHO FCTC, and we shall try to see how these governments are trying to protect public health and especially the tobacco control policies from the tobacco industry interference. As Mary pointed out, there are quite a number of indicators that we have used. There are 7 indicators which are mentioned over here. I won't go into details. It will Mary spoke about them, and I will refer to them in my presentation. So the second slide, the next slide is about the key findings of the Africa Index 225. We find that the tobacco industry interference is still very common in several of the 20 countries that are covered by the Index 225. I won't go into all the details. You will have it on my slides, which I have shared with you. And with regard to CSR activities, we note that the level of CSR activity of the tobacco industry is quite high in a number of countries, ranging from supporting fish farming, the installation of boreholes in certain countries, or building classrooms, or building meeting halls and planting trees. So all these CSR activities, as you should know, they are meant to build the image of the tobacco industry with governments and with the public. With regards to benefits to the tobacco industry, many countries in Africa are still giving tax exemptions to tobacco companies, or allowing duty-free um, cigarettes to be sold in airports or at ports, and also giving benefits to the tobacco industry with regards to the time allocated to these tobacco companies with regards to implementation of policies such as health warnings. So, with regard to conflict of interest, this is also noted in a number of African countries like Malawi or Tanzania or Democratic Republic of Congo. These conflict of interest, it could range from politicians or senior civil servants taking up jobs with the tobacco industry, or especially there is conflict of interest where politicians or tobacco farmers in countries like Malawi, um, and also where there is funding of political parties by the tobacco industry. And with regards to preventive measures, we find that not many countries in Africa have, for example, a code of conduct with regards to Article 5.3. So these are some key findings that of the index 225 in Africa. But at the same time, while the key findings points to widespread tobacco industry interference in tobacco control, there are still progress
Sorry,
that have
Moye.
been noted.
Hello,
Yes,
Moye.
yes.
I think there's a problem. Can you be telling me when you want the slide to be moved, please?
No, this we have completed.
Okay. Oh, okay.
We have completed this one.
Go ahead.
Yeah.
You are on
So
conflict of interest, preventive measures.
no. This is good. Okay. Let me. I was saying that despite the interference that we have noted in quite a number of countries in Africa with regards to the tobacco industry. There are still positive signs and progress that we have noted in quite a number of countries. For example, if we take uh, all the 20 countries that have been covered by the index, they have not had any representative of the tobacco industry in the official COP and MOP delegation. COP is Conference of Parties, MOP is Meetings of Parties. And also, if we look at Burkina Faso, for example, there has uh, uh, it's a country that have avoided all forms of tobacco industry interference in policy development. While in quite a number of countries have engaged in CSR activities with the tobacco industry, there are quite a number of countries where there has been no support at all for CSR activities of the tobacco industry, like Burkina Faso, Cote d'Ivoire. Um, uh, Conflict of interest, countries like Botswana, Ethiopia, Nigeria, Uganda, all these countries have laws strictly prohibiting contribution from the tobacco industry to political parties or to candidates. And countries like Chad, Ethiopia, Nigeria, Uganda, they have got the codes of conduct based on Article 5.3 of the FCPC. So these are a few findings from the tobacco industry interference index. I mean the Africa one for 225. Um, uh, Now, what are the strategies that we can use at country level to counter the tobacco industry? And what I'm going to say is already existing in several countries. The best approach is for having a tobacco industry monitoring team. And this monitoring team, it comprises of civil society, but also of several sectors. It could be the media, it could be government, it could be the WHO, and all other partners that are engaged in the fight for tobacco control and for public health in general. So having a tobacco industry monitoring team is very important as at the initial stage of monitoring the tobacco industry. And then, of course, there is capacity building of all these partners so that they can be engaged effectively in conducting tobacco industry monitoring. And when we're speaking of tobacco capacity building, it's also for government, all the people who are engaged in tobacco control. They also they need that knowledge, that skills, so that they understand how the tobacco industry interferes in policy making and how we can counteract the strategies, the tactics of the tobacco industry. Of course, advocacy for policy adoption, especially for adoption of of regulation law with regards to Article 5.3 is very important when we speak of tobacco industry interference. So advocacy for policy adoption, but at the same time, monitoring policy implementation is a key part of a tobacco industry monitoring team. What we are speaking is a standard approach in several countries with regard to tobacco industry monitoring. It already exists in several African countries, but it's not always easy, let's say, to implement what we are saying, having the media involvement, capacity building, advocacy policy adoption, and monitoring policy implementation. It's not always easy. There are quite a number of challenges, especially with regards to funding. All these activities require at least some funds, especially for sustaining the monitoring in time. But there are success stories in Africa. Kenya is a good example. Cote d'Ivoire is another good example where tobacco monitoring is done in a very sustained and systematic way. And that gives good results in terms of advocating with governments with regards to tobacco industry interference in policies. The case of Tanzania is a bit different in the sense that the level of interference of the tobacco industry is very high, as has been indicated by the global index with regards to its ranking, and even to its ranking in the Africa index, it is 18th out of the 20 countries that have been covered by the index. And my organization, the Africa Tobacco Control Alliance, has good experience working in Africa, where the tobacco control law has been stalled for delayed for several years now. We work with Tanzania some years back in order to try to have the bill adopted. Unfortunately, that attempt was not successful, but it does not mean that we have to stop supporting Tanzania. It's a difficult country with regards to tobacco control and being given the influence of the tobacco industry over there. But our efforts, I believe, should continue in future. With regard to the regional strategy in Africa on tobacco industry monitoring, I believe that the current state of affairs, the current status situation is quite supportive, is conducive. The environment is conducive for tobacco control and also for tobacco industry monitoring. and preventing its interference in tobacco control. Quite a number of African countries have adopted, have got their tobacco industry monitoring teams. Mm, there are 20 countries in Africa are now covered by the tobacco industry interference index. And we have got all the evidence with regards to how the tobacco industry is interfering and delaying tobacco control in Africa. We have got a media network that covers several countries. Media professionals who are engaged in tobacco control. We have got appropriate tobacco industry monitoring tools that have been developed and that are being used by quite a number of countries. And there is also increased willingness of regional bodies like the African Union, like Africa CDC, to engage in tobacco control and also in tobacco industry monitoring. So I believe that when we look at the continent, there is some positive signs that in future, in the years to come, we can continue improving on what has been achieved with regards to tobacco control and with regards to tobacco industry interference in tobacco control. And ATCA, as a Pan-African civil society network, will bring its own contribution in this fight against the tobacco industry and for tobacco control. We are working on having a more comprehensive program which will support the adoption and implementation of Article 5.3 for supporting capacity building. I spoke to Mary some time back about how we can work together with regard to building the capacity of African partners and within civil society and government as well, so that we can move forward with a more aggressive and comprehensive approach to Article 5.3 implementation. So we are working on quite a number of initiatives. Might be at a later stage we can speak in more details about it. But at the same time, we are Africa, as Mary also mentioned. Africa is also being faced with some more urgent issues related to the tobacco industry. It is the emerging, the new tobacco products that are invading the African markets, illicit trade, which is a big issue in several countries. So there are challenging times ahead for the tobacco control community in Africa. But at the same time, I believe that the progress that have been achieved so far with regards to the implementation of of the FCTC, with regard to adoption of Article 5.3, the progress that we have noted with regard to tobacco control in Africa and with regard to tobacco industry monitoring, as indicated by the Index 285. All these are indicative that we should have hope. There should be we should be able to challenge the tobacco industry. We should be able to move forward with our tobacco control so that in the years to come we can have we can protect our population from the scourge of tobacco and contribute in our own way uh, in promoting health throughout Africa. And the role of civil society will continue, be it in Tanzania, be it ADCA. I believe that we have got a very important role to play with regard to monitoring the tobacco industry and reducing its influence in policy making in Africa. Thank you very much.
Thank you, Moha, for that nice presentation. You've given us a broad picture on how the situation is in 20 African countries. Again, various countries are at various stages of adopting Article 5.3. Some are winning the battle, some are stagnant, and some are dragging back. And you pointed out Tanzania still has a very high tobacco industry interference, which we should take note of and find means and ways of challenging that. Now, you pointed out some of the strategy which are quite well, but you again reiterated that some of the approaches needs funding, which is not readily available. We will discuss on how we can speed up that so that we win the battle. Now, thank you, and I hope you stay with us for the discussion at the very end, Moha.
Yes, sir. Yes, I will stay.
Okay. Now, we have heard the situation globally, Africa region. Now, let's come to back home and we hear something about Tanzania itself. And for this presentation on Tanzania, TII, there's no other person who can easily tackle that other than Ms. Rutgard Kagaruki. And I don't think I need to introduce her. Is there anyone who doesn't know Rutgard? Rutgard, in one sentence, she's the executive director of Tanzania Tobacco Control Forum and a tireless fighter to ensure Tanzania abides with WHO Article 5.3 so that we also get into uniformity with other African countries like Kenya and Uganda. Rutgard, you are welcome to give us the picture in Tanzania, and we see how good, how bad we are in that relation. Karibu.
Thank you very much, moderator. I think you already know what I'm saying at the moment. Already read, and that's really shame when you compare our case with others. You have seen this slide already, that Tanzania is among the last 10 countries with most tobacco industry interference in the world. And this has been going on since the survey of the index. This was in 2019. We have remained in the race all along. We try to look at the global picture that it always has been stated already. We know that in 2023, we scored 79, and 2025, we have scored 18, gone up more than 1 point. The higher the score, the greater the interference. You have already been told about the architecture. We are number 18 out of the 20. We say that it is also not very healthy. And globally, we are number 10 among the 12 last ones. And 100 countries participated. As the moderator said, if you are careful, we will soon be the 100. And when we look at the points that we have considered when we survey participation in policy development, this is the industry participating in policy development. We know that in 2025, tobacco industry affairs has increased a lot when we compare to 2023. We have the Tobacco Products Regulation Act of 2003, which is not compliance with the Federal Convention on Tobacco Control. And we will be fighting Tanzania ratified the convention in 2007 to have the law change. And actually, we have a bill where in 2017, like the minister said, and try our best to remind them, because we all know the harm that tobacco does in Tanzania. So we have indicated like in the industry, and the industry interference. I mean, the tobacco industry has upscaled its tobacco advertising, promotion, and sponsorship activities. For those of you who go out in some centers, you will have noticed the kind of advertising and promotion that's going on. Tobacco production has also increased immensely, and it continues in the name of business and making money, but I agree with me, there's more roads than gain in tobacco, including tobacco production and use. Now, talk about patient of the tobacco industry. That is our former friend, Minister. When it can require a plan. Now, according to Article 5 of the treaty, this should not be happening. Because once a leader starts running together with the industry, then of course, there's no way to find anything. It's like to give them a leeway for the one. So I don't know if what something like a friend is for. But I think it was happening. And then talk about corporate securities, which are also banned under Article 5.3. This was a signing of a memorandum of understanding between the Tanzania government and Japanese Tobacco International. For them to support the community on health, education, and water in areas where they chase tobacco leaves. So you can see the limit of state from the Chinese authorities and the Japanese guy, random. But also on the right, we have our Prime Minister with the Japanese tobacco international guides. And this is, of course, contrary to Article 5.3 of the Convention. CSR activities are continuing. This occurs in the neighboring municipality, where the mayor distributed in thoughts, the deeds were supplied by the next year company. That is where about the it shouldn't be going on. Talk about the benefits to the industry. We already have the required factory. Now, unfortunately, in 2023, Honorable President inaugurated a cigarette manufacturing company alongside the lead position factory. And because Minister Kwame Kata proudly announced the increasing output of tobacco and at the goal of reaching 400 million USD by 2024. So, go again with that. And there is no way Tanzania can progress along this line. From the financial interaction that we may talk about, we know that the government continues to support it by the tobacco industry and private interest. And we know that Tanzania Cigarette Company was recognized as one of the most compliant taxpayers at the national level in the manufacturing sector. And the award was presented by the Honorable President. This is all in favor of the industry. May I also mention the President, the CEO, Philip Morris International, which belongs to the Vatican, and Philip Morris International, they committed purchasing 12,000 tons of tobacco in the next 5 years. And this, of course, translates into the increased tobacco farming. Talk of transparency, you have the Tanzania Medicine and Drugs Authority, the US, for inspection of tobacco production, and all tobacco companies are required to disclose and register with them. But there is also the Tobacco Industry Act, 2001. This requires, among others, that registration or deregistration of tobacco farmers. But we also, the Act also established the Tanzania Tobacco Board. Now, unfortunately, neither TNA and or TPP, Tanzania Tobacco Board, do register the affiliates. And these are the ones that further the interest or the officers will further the interest of the tobacco industry. And the fight for it is all of these things happening. So no one has that the name in the race. Now, talk of conflict of interest. Government does not produce the tobacco industry. I would require and supply this. And many talk about government employees, including employees by the industry and by the we have our retired Chief Justice. He just retired. And he was actually the new board chair in the Tanzania Cigarette Company. Now, this person still has a lot of things. So we can build further in that intent. That's why fight for it complete. This also an example Bakari Magu was appointed by 16 in January 01 as a non-meeting of government, integrating minority shareholder. And prior to that, he was the regional director for Beta into the government. You see the examples of Spain in Tanzania, where they have years, 5 years, before one can join the business. So these people have to influence, and they can easily further the industry. Now, talk of preventive measures. We are supposed to put in place a procedure for disclosing vectors of interaction with the tobacco industry and with the interface. We need to have a code of conduct to the public officials, as I just indicated. We need to require the tobacco industry submit all their information, including their lobbies they don't do it. And we know they do for it for the and that's what is happening. We need to have a program consistent to create awareness within the business of health, and even within the we need to have a inform the public about the data. We need to have a policy in place to disallow acceptance for institutions from the tobacco industry because that's from the public health. Yeah, now our recommendation, we have guiding principles of Article 5.2 of the FCC that requires government to observe the following. First, we need to establish measures to limit interaction with the tobacco industry. Mary did indicate that whenever the government official meets with the industry, it should be transparent and only when regulating their products. Like when you are telling the cigarette factory, put health warning labels on packets, labels that will deter people. Like if you had a huge heart that is affected by tobacco on the pack, you know, people would be scared for saying so. And, you know, we have these examples in other countries, but you know, the part of Tanzania, you know, here, you see on the text, very small, 30%, tobacco in our here, which is no good. And for majority of the smokers, they have no time to read that. But if you have a huge disease lung, you know, even those that can't read can easily come back. We need to establish measures to limit interaction, as I said earlier. We need to reject partnership, like leaders couldn't be rapid products in the industry. And we need to avoid conflict of interest for government and other employees. We have seen in Australia, this does not only end as the Minister of Health, cuts across all government employees. So you can see that we still have a long way to go. Now, to fulfill its obligations under WTO FCC, government needs to table in Parliament the tobacco control bill that has been lying within the ministry since 2017 to be able to protect the public, in particular the children and youth. And these are the main targets of the tobacco. We need to put an end to tobacco-related corporate social responsibility. We need, you remember in 2014, we did South Road, and the Prime Minister did ban shisha. And actually, shisha disappeared. Almost like your areas. But I did caution that a ban without a legal backing is not going to be sustained. Now, for those of you in the entertainment centers, you will agree with me how shisha has now spread like wildfire. Basically, at the moment, the majority of us are smokers from second and third. And I've said this at the time, the Pakistan, the Western world. Within 5 to 10 years to come, you will not be able to cope. You won't be able to cope if 10 measures are not taken. Tobacco advertising, promotion, and sponsorship are talked about this. It needs to be banned. We need to stop the introduction of new farms because there has to be expansion. Farming, tobacco farming has been decreasing globally. In Kenya, they have a special government program of tobacco-free farms. In Uganda, tobacco farming has disappeared. Now, for us, we are boasting of increasing the tonnage, and that is not good. And the cost-benefit analysis of tobacco business is that more people suffer and die from tobacco use than any benefit that it is the economy. We shouldn't be giving incentives to the tobacco industry. In the course that said area, we need to be very code of conduct to bar these unnecessary activities. Now, I like to see that. You know, these are all disease-causing industries, and they are helpfully showing that how they need to be. Number one is here, that it brings in 472 billion shillings. Second is cigarettes, brings in 200 billion shillings. Third is hard liquor, that brings in 168.7 billion shillings. The fourth is soft drink, 127 billion shillings. Next is sugar, all the bad things, 91 billion shillings. And lastly, you have cement, which is profitable for us, 36 billion shillings. But then we have our land. From the investment case for tobacco control that we did in 2023, and this was by UNDP, WHO, Ministry of Health, and some of us. Tobacco causes 21,800 deaths a year. That's a huge number. And these are deaths that money can never pay for. But the total socio-economic losses from tobacco was 820 billion shillings. Try to compare that with the 200 billion from tobacco sales. Professor Kaushi, in your them. How did the two times?
Oui.
200.
Il est là. Tu vas manger, fini midi.
And this has been broken down from this, that causes 327 billion losses. Healthcare expenditure, 110 billion. Workplace productivity losses, that is 357 billion. But that excludes the environmental practices. That is enormous, and that no money can pay for. So if you look at it seriously, there's no business. And if I had time, I would have talked about tobacco farmers. They are paupers. They're very poor. They get sick from tobacco farming. They end up with the same excuses. So generally, there's no benefit in tobacco. Finally, I just want to say that it's possible to have a tobacco in Tanzania. We have seen with our colleagues.
How you mute it? I am having difficulty with.
Can you mute them, please? And
Okay,
we
thank you.
have all these alternatives. You know, we have alternative crops, and we have done that in some areas. And, you know, majority of the farmers don't want to do tobacco farming because it is expensive. It makes them sick. It makes them poor. It destroys the environment, diminishes rainfall, reduces biodiversity. So farmers are willing to change. But the strength of the tobacco industry interfering in Tanzania is just way too high. And this is what we need to talk about. We need to advocate to our leaders. Well, they know, maybe they don't, but we need to have this advocacy. And when people like Dr. Kitenge, Dr. Manhata, Dr. Kaushi, Professor Karim, Musa Bingwa, and all the medics, when you talk, you people listen. So we want you to talk. Maybe they will. Thank you very much for that.
Thank you, Madam Rutgard, for that nice presentation about the situation in Tanzania. Well, At least you have given us points to discuss on why are we dragging behind the other countries. You pointed out 4 issues, and I think the audience should take note of these so that they are the basis of our discussion in our efforts to look for the way forward. 1, there is high government involvement. 2, lack of transparency. 3, conflict of interest. 4, there are preventive measures clearly documented, but when it comes to Tanzania, none is in existence. So what do we expect out of that? Please, the audience, take note of that. And thank you, Madam Rutgard. So we will base on those to discuss our way forward in improving the situation. Now, Rutgard mentioned about tobacco and health. And it's time now to address that in depth. And we have 2 speakers who are going to address that issue. The first one is going to be Dr. Peter Kisenge. And Dr. Peter Kisenge is the executive director of the Jakaya Kikwete Cardiac Institute, bringing over 10 years of managerial leadership, 25 years of medical experience, and 15 years in intervention cardiology. He also served as a personal physician and health advisor to the late President of the United Republic of Tanzania, John Pombe Magufuli. And he's also taking lead in mentorship and assisting other programs to tune up in improving access to cardiovascular services in Tanzania. Dr. Singh, we are in DKI now, and he's our host. So we thank you for offering this space, and we will thank you more when you address the tobacco and cardiac health affliction. You are welcome. Yeah.
Then I think police the parents very first and people first me like for I mean that So we can take it here. Able to assist for innovation and I on the one president. It's only after 2 years. First registration is for Cuba.
to place that this all the way from our new branch information to Dar es Salaam, Gambia, then go to the balloon to leaving them for the layer in the so this is the really guiding and flexibility. So our talk today is about the use and the cardiovascular disease. And so 8 million deaths annual of cardiovascular. 20% of cardiovascular activity. Those of you so there's a rising population of this particular issue. If you go to area of the town, it's the place where it's north of it. It's a north of it. Think for 10, 6, 8, maybe some of them. So the different testing is there's also increasing of flooding, and we see excessive flooding to be specific. Now, if you look also in the here in Tanzania on the near otherwise, you are also facing if things are facing post-war, yeah, to say, and how people couple up with the plan, 5 couple. I know that we'll take another couple in our region, but 1 couple for the party. So really see what they have. So what will happen on the so this whole will be to make it close at this at the top with source from the inflammation of the district and for thousand of the district, that's why with a multiplication panel is based with your can find anything but the history and stuff. So these are the effects of so that was when the Africa the question they are going to get the end up. So I also question and relate. So they think that you can active for life. This is a rate sometimes we don't have it. Now, if you look what are the factors, so we have to create a history. The people are there. Yeah, flag reason, so the accuracy of immediate long sometimes we are also seeing some the patients were going to be, those of them when start the people with children. If you look on the comparative risk factor, nothing like it. So we did an outreach program where we did the really research that somewhere. So we were looking for the risk factor. Nothing sympathy. What is it? The area of Dar es Salaam, Arusha, Kilimanjaro, and Mwanza is the region. So smoking also increased what the English is like 25 to 30%. And this is really important public policy. So if you keep now, there's a lot of benefits. So you see, you people reach the person about that. And you can easily see, instead of running of what are the economic burdens? I know there's a lot of China, for example, in our country, but for that, we need about the money, money from medical facilities, purchasing capital, people are dying, too much of this, young people are dying, so this is really something that because economic burden, company have for the conservation, healthcare expenses, and so we need to policy conservation, more below public education. So, as an the country we are going to our education campaign. This campaign for your numbers, you answer that. And that campaign where we are also going to look on the risk factor. And we nothing we want to give you risk factor, so we are going to create an awareness to the 70% of that. So we are going to start Dar es Salaam. There will be a special campaign for working in social alcohol reduction. So we see this loading here. So conclusion to that is the leading to that study and for clinical for energy which is really important. Thank you very much.
Thank you, Dr. Kisenge. And now you actually digested out or dissected out all the effects tobacco is likely to cause to the cardiovascular system. And the cost involved is quite enormous, as you indicated, and we need to take action. Now, in your final remarks, you said you are going to make a campaign, which is a good idea. My plea is if we can join up hands, the Akaya and the other groupings who are addressing tobacco control, that would be much better. Please think about that so that you join up with others so that their voice gets bigger and you are more likely to be heard. Having heard from Dr. Kisenge, the other area affected by tobacco smoking is the respiratory system. And to address that is going to be presented by Dr. Ki Mwanada Kilima, who is a pulmonologist and the president of the Association of Physicians of Tanzania. I know you have a long CV, so in the interest of time, I'm shortening it up to there so that we may gain some time for discussion, Munaid. So you are welcome to present the effects of tobacco on the respiratory system. And you are welcome to start your presentation.
Thank you, Madam President. Very nice with that is saying that we have a commission. We are simply starting with ongoing nothing other. And also the disease by and force by. My title is Chronic Non-Disease. We're going to have to look at it and period, and so you can use the answer divided by chronic by clinical practice the time to our data, so it's a very high frequency. Especially during the system about mental after the significant now, you don't have to dive away from non-outcome yet, because of the way that very high sometimes it's unclear situation that is regular failure or other failure to really realize it is long time. So there is a challenge in that. But another important point down to the country is possibly language. With a time more than 90% of the this is just now. What is more concerning is the fact that many information is not diagnosed, then also access to diagnosis when the disease is very much limited. In Tanzania, it's a double whammy because it's not both infectious diseases and infection, lung infection. Led by this disease and these numbers have already been presented. Many of our patient groups being to at least 1,800 deaths annually. These deaths are prevented, whether for cardiovascular, lung, malignancy, and any other cause. The death and unfortunately disease burden is also contributed by growing epidemic of FIFA use. Dr. Kitenge mentioned Makati area, but I assure you, even in villages, nowadays we have fish. Even in villages, this is a Hazabe mine in the interior of the forest, somewhere in Naruto or Manyara. Fisher does it, have here everything. But it is also sudden that these are marketed as safer smoking alternatives, while it's actually the opposite. 1 hour with a shisha apparatus gives you 100 cigarettes within an hour. And if you are a smoker of shisha, you are a smoker and a coal miner at the same time because of all the chemicals and constituents. What is more saddening is another surge of smoking, which is crazy, even among our age people. These again are marketed attractively. And children are attracted to them because they're small, they look like friends, they look like toys. So children are attracted and they think it is safer And actually the health risks are the same and sometimes worse than conventional TB. With that, we don't only have smoking as a burden, but with regard to chronic lung disease, we are facing smoking as a huge contributor, but also biomass exposure. We support and we understand that there's an ongoing campaign nationwide for alternative energy use, especially gas. But the fact remains that it is not enough yet. Accessibility and cost gives us still a high number of rural households need to use biomass fuel. And with that, biomass and smoking, COPD is on the rise, asthma is poorly controlled, the early onset of lung disease because of poor lung health, but also secondhand smoking and exposure to biomass among women and children who are mostly affected. So trying to show how much we don't need smoking at all because we already have a problem with biomass exposure, especially in Europe. So that is why our COPD prevalence is very high. In children, for example, who are exposed to tobacco from their parents or family members, the asthma becomes very difficult to control. These are the children who come back to the hospital and we try to ask why when they receive optimal therapy, but they are still not controlled simply because a family member, a parent, is smoking. But also they have a more severe form of the disease, and these are the young COPDs. They will come at 30 years of age. In the past, we thought COPD was among 70-year-olds, but now we have the very young COPD patients because of early life smoke exposure from family members, from vaping. As Madam Lucia correctly said, in the next 5 to 10 years, we'll not be able to cope with the burden of cardiovascular, respiratory, and disease. COPD has already been discussed. Now, looking at the economic burden, chronic lung disease is not a one-time thing. It's a progressive, long-term condition which imposes substantial ongoing financial burden on families, but also on the entire public health system. The economic impact is driven by what? Continuous medication use, which is good, but also frequent hospitalization, emergency rooms, diagnosis, death, and also loss of productivity. And therefore, in chronic lung disease, it's a financial cost. I think any other disease caused by smoking or it's a financial cost rather than a one-time illness. Once you have chronic lung disease, it's a lifetime problem for yourself, your family, and the entire community. Looking at COPD, for example, globally, it causes 90 to 100 million disease-adjusted life years. And this is contributed not only by direct education and investigation costs, but also absenteeism from work. COPD and asthma patients miss their daily activities very often, sometimes once a month, sometimes more often than that. In average, a patient with COPD would spend 2 million Tanzanian shillings per year. This is, for example, if they are stable disease, they just have to come to hospital for clinic. Their expenditure for OPD clinics, their expenditure for inhalers, for X-rays, for lab tests a year, it gives us around 1,000 USD. That is for one patient per year. If at all they are more complicated, which is usually the case, as the first thing will say, the family, therefore they are more disease, they have more exacerbation. With that, total expenditure per year will go up to 2,000 USD per person. So once you're talking about low cost expenditure, on the minimum basis. Without talking about lung cancer, again, many lives lost because lung cancer is the leading cause of cancer-related death. It's not the most prevalent cancer, but most lung cancer patients die. They die. Whatever stage they come, death is imminent. So it is the first cause of cancer-related death worldwide, and we believe it's the same in Tanzania. Just like COPD, expenditure is related to direct and indirect costs. Ocean Road will not be able to cope. He's not even able to cope now with biopsy, imaging, lab, chemotherapy, radiation therapy. Very, very expensive. Not to talk about long hospitalization and family. But family members find themselves stuck. They are stuck because they have to look at that young lady. She's healthy, but she can't go anywhere to do her business or go to her office. There's no economic activity even among the patients. We understand. Well, we too sick to go to work. That is a loss of productivity. But so family member, this is yes. So you have 2 or 3 people or even 4 people stuck. They have to drop whatever they're doing to take care of someone whose disease could be easily preventable. So my point today is that chronic respiratory condition is not a medical condition only. It's a lifelong financial burden that we cannot afford as a family, as a country, as neither. And therefore, to strengthen tobacco control is a critical step. Preventing the disease, but also lower the cost of these diseases and protect not only the public health, also national economy ability. Thank you.
Thank you, Madam. Again, like the previous speaker, she has just narrated quite a number of health effects accrued from tobacco smoking that affects the respiratory system. And again, like the previous presentation, when you do a cost-benefit analysis, you find actually it's very expensive to take care of a respiratory disease, and this is preventable. Now, we have just addressed the only 2 systems afflicted by tobacco, but the whole body actually is afflicted. And if we are to present every system, then we'll leave here by 6 p.m. And we don't want to tire you people. But I was wondering whether these cost-benefit analysis, the 2 can join together, give a big evidence base so that we can present it to the policymakers. They should stop saying, oh, tobacco is good for the government. We are getting money. We aren't getting money. All the money you put in the pocket, and this pocket has holes, it drops down, you end up with nothing. So, Madam, thank you for that, and thank you for all the speakers. It's now time to sit down and deliberate from what we have heard and see how best can we move forward. How best can we move forward? And that brings down to the last but one item, general discussion. Now, I'm going to be a bit provocative. At our last launch, we highlighted some way forward. I don't know whether, Rutgard, are you in a position to update us so that we don't become repetitive. If we are addressing those way forward, we shouldn't start now mention them again, but get updates and see how we can improve it. Together with this discussion, for those who are online, it's time to ask questions where things were not clear. So we'll take both at one sitting and see how we move. May I first have just a snapshot of our last way forward? How best have we gone? What have we achieved? Why have we failed? And then we snip up rather than starting afresh. What you got? Anything?
What am I supposed to say? Why have we failed?
Hmm?
Am I supposed to say why have we failed?
I'm saying last time we narrated a few things in our effort to improve the situation.
Our last way forward, you mean?
Yes. But now instead of improving, we are sliding back 2 steps.
Yeah.
Yeah, so
Actually, if you ask me now, I think we've like gone back 10 years. I believe we were doing much better, maybe like 3-4 years ago. Because as I said, 2014, Shisha was banned. At least that was one burden off. Now at the moment, as we've heard, it has spread like wildfire up down to the village. And it does not only affect smokers, but there are also lots of non-smokers. And those of you who have seen Shisha smoke, it's such a huge puff out, it's such a huge output. If you're smoking in the house, consider your whole family under risk. And prior to that, we were talking about the bill going to Parliament. The past health minister, Honorable Umi, had promised in 2017 on World No Tobacco Day that come September session, the bill will be tabled in Parliament. And I told them that go tell Madam Umi that Rutgard, for the first time, she will sleep peacefully. But to date, well, unfortunately, even some people are scared if you talk about it. So things are going from bad to worse. Maybe, maybe I shouldn't be the one speaking because Dr. Kisenge, what do you think we can do?
Sorry, before you go to Dr. Kisenge, do we have someone from the Ministry of Health in this audience?
Unfortunately, I did invite them online and they promised to be there. I don't think they are. I'm not sure. Some had promised to be online.
Okay, there is none. What? Anna. Madam Anna. Where is she? Anna.
Disappeared.
Huh?
She's disappeared.
Oh.
But we have another lawyer. Oh,
yes.
also
Actually,
disappeared.
I said I'm trying to be provocative. Apart from what you've just said, I thought we talked about litigation or
The legislation.
litigation.
Oh, the litigation.
Yeah, I remember.
Yeah, the litigation is going on.
Is going on.
Actually, tomorrow we have a court session.
So we shouldn't discuss that.
In case you're not aware, Dr. Kisenge,
Okay.
after trying so hard and for so many years, and we thought we had done it all, talk of advocacy to members of parliament, to key ministries, to ministers, permanent secretaries, directors. We have been everywhere. So we thought maybe it was time now we took a different route. So we went to court. We are suing the Minister for Health, for Agriculture, the Director of NEMC, and the Attorney General for not doing enough to protect the health and the environment of the Tanzanians.
Okay.
We
Okay.
might not win the case. We should actually, but we believe it is good advocacy for us. The message will go across. Because when you go outside globally, at the moment, Tanzania is in the black spot. And we need to do something to come out of it. We are getting worse by the day.
Okay, that's enough for update, Rutgerd. I wanted to refresh my mind where we are. So I think the audience, we should now discuss what has been presented and see how best we can move forward. But the key issues, I think, thus were highlighted is stagnating our progress, were one, high government involvement with tobacco industry, lack of transparency, conflict of interest, and lack of the non-preventive measures which would impact or lead to effective tobacco control. So we should discuss with that in mind and see how best we can address this. The audience, you are welcome to present your views and ideas in relation to moving forward. My name is.
So, giving the closing remark, but I thought of using this also as a forum to discuss some of the things affecting children. But before I discuss the stories how children are affected, maybe I will say the irony or the double standard of our leaders. And this booklet is putting very boldly with names and pictures of what's going on in the nation. So the irony is we banned shisha, and the Prime Minister himself was the one who spoke in public about banning the shisha in Kariako, Masaki, etc. But he's the one who went and opened the Mkwawa tobacco leaf processing factory. While we are advocating smoke-free environment for cooking, so no more charcoal, no more firewood, and use of gas to reduce the emissions of smoke. But we are the ones who award tobacco company as an award-winning for tax collection. You see the irony, there is so much double standard. So I am actually dismayed, as always, about the double standards on issues of health and related issues. As coming to children, I'll just narrate one story. Last month in my clinic where children come for treatment, this mother came very frantically. The child's asthma has become worse. And we did all that nebulizing and prednisolone and whatever. But still, the child wasn't getting well as faster as expected under usual circumstances. So I asked, Mama, is there anything new which is happening in the family? Cement exposure, painting, maybe something new, you put a new carpet, any other things? He said, no, I have shifted to my father-in-law's place because my husband has traveled. And my father-in-law is a chain smoker and he smokes indoors. I said, that's it. You need to separate from your father-in-law. Call your husband sooner to be back so you can go back to your husband's home. And actually, honestly, this is exactly what happened. He cut short the trip because the child was getting sicker and sicker. He cut short the trip. They went back to her own home. And in 2 days, he started becoming better. Now, whether it was the effect of medicine or the change of environment, anybody can guess, but this is it. Environmental tobacco smoke. Environmental tobacco smoke is not the smoke. If I smoke, whatever sticks onto my shirt or even onto the wall in that matter has got so many chemicals which can have very detrimental effect. That it has also been studied that early exposure in infancy of environmental tobacco smoke can actually even have an effect on neurodevelopment on these children. So are we creating a bunch of dumb, poorly neurodeveloped children in our own families? Question mark. So it has a lot of effect. And as a pediatrician and representative of Pediatric Association of Tanzania, I thought I use this forum to drive home my specialty. Thank you.
That's okay. That's a good example, and what you've narrated actually falls under two points I mentioned: the high government involvement and the lack of transparency. And we should find solution for this. Otherwise, we are banging the wall. We are the one to get our peace without any. Dr. Sen. National? Yeah. 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 Sure. Hmm? Okay.
Patients, including even telling the minister, maybe the minister they don't know anything regarding the effect of smoking. So if we go and tell them, maybe we need maybe to unite ourselves and come up with a strategy. I think maybe we are lacking in something. The strategy to involve in, for example, society, Vision society, all this society.
Yeah. Well, the ideas are good, and Dr. Singh, actually, I was provoking you when you said you were starting a campaign, and I thought those were part of the yes, and that's why I was saying, oh, if you can join up with all the other grouping, then you become, oh, then we might be a little bit more effective. I agree with what you said, but let's do it in a big move rather than consider JKI alone, TFCSF alone. We should find means of joining up and moving forward. I can see if Professor Kaushi wants to say something. When I say TANCDA, I think he wanted to say something. I know they are doing this campaign, but I'm saying we should move in a bigger voice than one at a time. Professor Kaushi, you want to say something? By the way, before you say, is there anyone taking notes? Pretty good. Oh, you must say, this should be. Okay. So, you okay. Oh, you should, because we need this meeting proceedings. Okay. Yeah.
Very much.
It's being recorded. Okay.
Yeah. Yeah, so thank you very much. I would like to appreciate the presentation by Dr. Kisenge and Dr. Manada. And I think one of the approaches is how does the tobacco affect the different specialities? And I think if, as an association of physicians, Dr. Manada, if we can get different subspecialties, everyone to look at the burden of tobacco on the system and give 5 minutes to each of the different specialities and subspecialties and prepare a comprehensive presentation of about half an hour of how it cuts across different specialities and what is the effect. I think it'll have a great effect. Second thing, I think you narrated the cost. Dr. Kisengi also narrated the cost of angiography. I'm not sure, but if we can get somebody to look at the economics of how much are we now spending in angiographies and how much we are spending in cancers, respiratory cancers, and what is the burden? Because when you go to the policymakers, what you need to show is that the tax being collected and the amount you are expenditure, which is a better solution, you see, is that because we always look at the revenue, is that this is the amount of revenue which we are earning. But then how much we are spending in the public expenditure with these zonal hospitals. And if we can at least get some sort of a data, just a case study or a data, it can help. Third thing is, I don't know, Mama Ruthgard, there is this United Nations, UNITAIDS or somebody who actually come and do a country case study of looking at the cost effectiveness of the intervention. Whether we have had that because they do it free of cost, and whether we have approached that if we can look at the tobacco and they actually go through all the data online and are able to come up with the cost effectiveness that this is the amount of tax you are collecting and this is the amount of expenditures you are spending on this one, and what is cost effective. Is it to collect the taxes or is it to just do the intervention? So I think if you are going to talk to the policymakers, you need to have that financial figures there to show the cost effectiveness, and I think that is most important. And my suggestion would be to reach out to these UNITAIDS, or is UNITAIDS, or I'm not sure, there's a United Nations agency which goes into the country and does the cost-effective studies. I think Malawi has done it, and then I think, if I remember well, Ghana has done it. And the best example for tobacco intervention is Ghana. No, in Ghana, I think they've really moved mountains. And I think it is a case study to look at how they've done it. And they've actually had all the figures, the economic data, the health data, and the burden, the taxation, and they've managed to do that. So if we can, by Zoom, I'm sure Happy can contact Labram, who is with the Ghana NCD Alliance, you see, and he can actually give us a case presentation of how it can be done. So it's something which you can learn from and try to see. Otherwise, we'll keep on shouting, we'll go away, others will come and still continue shouting. Yeah. Thank you.
Thank you for that. And I think I always want to know who is doing what. From Professor Kaush's presentation now is telling us Ghana has done quite well and we better learn from them. And that Happy can lead this by contacting them and see whether they are going to help us with the documentation on how they approached the issue until they got some. I think Ghana was high up. Yeah, it was doing quite well. So we should learn from them and see how we can use their experience approach to see how it fits in with Tanzania and move forward with it. I hate this always, we are just stagnating. We are not moving forward, we are moving backwards. That's disappointing. Happy you will do that for us. I think Happy is inside this. Okay. You have taken on that. Okay, that's action number 1. Any other idea, Rutgard?
Thank you, moderator. Oh, sorry.
Dr. Manada is the chair of the Association of Physicians.
Yes.
I think, the presentation made by Dr. Kisenge and by herself.
Yes.
8 or 10 slides, but it passes the message. I think we should ask different specialties.
Yeah, other specialties who have those database.
Yes.
It should be put together. Yes. Who is doing that now? Dr. Manada.
Is the chair
Okay.
of the Association of Physicians.
Yeah.
To get it.
Okay. Is cost benefit.
Yeah.
Okay. Dr. Manada. Okay. Go ahead.
Could we meet more often for this particular agenda rather than once in 2 years for the launch of this?
Certainly, yes.
Yeah, because the last time we ever met was 2 years ago. Isn't it, Madam Lutgard?
Yes.
Apart from that, the rest of the efforts are individual or institutional or society-based, but together in the fight against tobacco, we have not had a unified approach,
Yeah.
at least a regular one for that matter.
Yeah. Yes.
So my plea to all stakeholders present today, maybe Madam Lutgard or Happy, can organize such a movement.
Again,
Unified
I want
movement.
to task someone who is going to do the coordination for regular meetings.
Happy,
She already 2 minutes.
yes.
I suggest Happy and you get free, no charge for phone if you want to use it yourself.
Thank you.
Okay. So we have now 3 forward approaches. Am I right? Huh? 3. Yeah.
Yeah, Chairman, I think at some point, from what Dr. Kisenge is mentioning, I think some point we had this multiple professional association. And at one point, I remember we had this coordinating bodies that was all the professionals. I think we should have a meeting with all the secretaries of the chair of the professional association, meet and then have a strategy professionally, how are we going to take it out? You see, take off the agenda. That is on the professional side with the data and with the impact which it has.
Yeah.
The second one we said is that when we have that meeting, we can have this learning from the Ghana. We can connect
That
him
was
on
one.
Zoom. Yeah, we
Yes.
can connect him on Zoom and have that meeting to understand how did they do it. So you have a learning curve there. And the third one is this United Nations agency. I'll try to communicate with them and try to see if we can do a cost-effective study for the country. Yeah.
Those are the 3 I
Three
was
things,
mentioning.
yeah.
Yes. Okay. Ladies and gentlemen, any other view, idea, concern?
And my suggestion again is that since we have a new Honorable Minister for Health, it would be worthwhile sending a letter to go and see him
and try to see if something can be done. I'm sure you might have done it because you're very fast at writing letters, but I'm not sure if this has been followed up.
Well, I think Rudyard had decided with the two ministers, contacting them, meeting them. It ends in mouth, not in action. That's the problem. Rudyard, tell us.
Moderator, together we've been visiting them. Don't try to run away. But, generally, globally, when we talk about tobacco industry interference, and I said this even at the conference of the parties in Geneva, it's not the industry that is the problem. Because there are tobacco companies in Ghana, if you'd like to know. We have tobacco companies in Kenya. They are there in Uganda. They are there in Mauritius. It is the political will that should come first. We can call Abraham, we can strategize. Muta, we've been in Dodoma with Muta, and actually I was also contemplating, shall we maybe after this go to Dodoma? But then you wonder, is it going to help? We need political will. And now that we have new people in government, we have a new minister, and we have a new minister for agriculture. I don't know his perception. We need to start with those political leaders because they are the ones who decide. If you talk about the investment case in tobacco control that we did, it has everything. The cost benefit that you're talking about, it's all in there. Well, it would be great if Dr. Kisenge, Monada, Kaushik, and all of them could come with their figures. But the investment case actually is the one that we have been taking to court. And those people have failed to challenge it because the figures are clear. We need to convince the decision makers. We can have all the information. Talk of taxation. In 2018, WHO, CDC, Ministry of Health, they did a taxation study because taxation is the best buy in tobacco control. If you raise tobacco taxes to the WHO recommendation, that is 75% of the retail price, you see a drastic fall in smokers, a drastic fall in diseases, they go together, and an increase in government revenue. But the industry doesn't want that because it robs them of their potential customers. Those are the youth. So this study was done in 2018. The report is there at the Ministry of Finance, and it's been refused to be released. Lack of political will. So we need to convince political leaders. And maybe because we have new people, we need to go to Parliament. Dr. Kisenge, if you go to Parliament and speak to them, that will make more sense than us sitting here and giving all these nice reports. Have reporters, those people don't read, We need to strategize to go to them, convince them, and then put it in the media. Maybe that will have an impact. Because tobacco is everywhere. It is in Australia and New Zealand. Those people are doing, very well. But you can cap the industry if you have tobacco. If you have political will. That's what I can say, Honorable Moderator.
Thank you, Rutgerd. Yes, I agree with most of what you have just said. But in addition to say you already have data, it doesn't stop to enrich the database. And this is what we are saying. these specialties, if they have data, they sit down and pull it down together. Be Dr. Kisenge going to the parliament, he goes with that data, he presents it. But the other thing, you people you're overlooking, the stumbling block is not a political will. I think there is also an issue of conflict of interest. You are saying you have leaders. You need to study them clearly. These leaders, don't they have conflict of interest? We were going together, yes, you said, but at the very end, we realized, oh, we are talking to people who already have tobacco farms and what have you. Now, how do you go and convince those people? How do we remove this conflict of interest? These are the issues to discuss. You don't know all these new leaders you are talking about. Don't they have a conflict of interest? Where they will listen and say, yes, yes, you go away, everything else there. As long as this conflict of interest is not addressed. I don't have the answer, but we need to discuss. I think the conflict of interest, I don't want to be taken now, but I know top officials, please don't take me somewhere, but are also involved in tobacco farming. So how do you convince them? Anyone with an idea? I'm here, Minister for Health, and I have got hectares and hectares of tobacco, and you come and tell me tobacco is no good to stop it. I will listen and say, okay, you will go away, and the business continues. This is what we are facing. If we don't have people who are fully committed, they don't have conflict of it, yes, we will win. But as long as there is conflict of interest, I don't see. What do you have?
Yes, Chair, you know, they may be having farms or factories or whatever, because the law doesn't prevent them from having those. If we can manage to convince them to pass the law so that we say no smoking in public places. If you smoke, you're taken to court. You know, no advertisements. You can still do your business, but please don't advertise, don't promote, don't use the youth. And at global level, actually, at the moment, they have these global youth voices. And that's what we should do, to organize the youth in Tanzania, to speak up, you know, mobilize many youth, because they are the major victims. They are the victims of the tobacco industry. They're the ones that are advertisement, promotion, it's all about them. So if we increase these voices, then maybe the message, you know, we need multiple approaches. I see Mary shaking her head. Maybe moderator.
Yes.
Maybe she can tell us something, Mary?
Mary.
Sure. Thank you so much, Lotgard and Honorable Moderator. Thank you for allowing me to provide some input. I agree 100% with Lutgard in terms of mobilizing the youth voices. And I want to say that in many other countries as well, the government cannot, or rather policymakers and politicians cannot ignore the voices of youth. Let me tell you that every time a child smokes or a minor smokes or uses shisha, the industry is illegally making money out of that child. every time a child smokes. It's illegal because tobacco companies do not want children and minors to smoke, but they're very happy to make sales and profits from children smoking. And the government collects money in terms of taxes, including from children who smoke, and nothing goes to the children. So, in fact, in the ASEAN region, in several countries, we have started to document how much money the tobacco industry is making just from sales to children. Because, policymakers don't seem to be interested in all the data that was provided earlier on long-term chronic illnesses and the cost to society. And Lutgard is correct that, the suggestion for investment case study for Tanzania was completed in August 2024. More than a year ago, it's been sitting there with all the data not being utilized. So it's time to actually pull that out. So I want to go back to mobilizing youth voices. The problem has to be presented from the perspective of youth. Because if the policymakers and politicians are not interested to protect adults, they cannot deny protecting children. And I can tell you that the industry and policymakers are practicing double standards because the industry in many other countries has already banned advertising, is not allowed, smoking is banned in public places, no pack display, in retailers. In fact, retailers have to be licensed in Japan, the headquarters, of where Japan Tobacco is a Japanese company. Cigarette retailers are licensed, but they are not in Tanzania. So the industry practices double standards, and politicians get to travel overseas. They get to see what other countries have done for tobacco control, and that doing tobacco control does not cause the economy of a country to collapse. Politicians have seen that, and yet they turn a blind eye when they come back to Tanzania. Suddenly it's, it's good for the economy. We need tobacco. If you look at the T5, the 5 tobacco growing countries in Africa, they are among the poorest countries today, Malawi, Mozambique, etc. Why dependent on tobacco? If you look at Kenya, because if you want to look at what other countries have done, parties to the FCTC need to get farmers to shift to alternate livelihood. Kenya, tobacco farmers have started to grow food crops because it fetches a higher price than tobacco. So farmers, don't get paid, a decent price for every kilo of tobacco that they sell. They get the really, the shoddy end and are deprived, of good prices because they don't control the prices. The prices are controlled by middlemen and also by the industry. So the farmers are losing out anyway. So several points that I have raised, and I agree. The third point that I agree with is to regroup and to strategize. I think you need to do that. The president of the Association of Physicians is present in your midst. It's a powerful NGO. In other countries, including Australia, this NGO has actually really been, mobilized for tobacco control. So therefore, regroup, strategize, utilize information that's already there, and mobilize youth voices. Thank you very much. Back to you, moderator. Thank you.
Thank you, Mary, for that input. And I hope no one is arguing with what you have said. We should incorporate those. Dr. Senge, I think in your campaign, one of the focus group or target group should be the children and the young ones. We should focus on those and see what benefit can we get out of it. Rutiga, do you want to?
Yeah, I just wanted to request you, moderator, to take 2-3 minutes to launch the report officially. I would request that we go by those placards and take a picture
Okay.
to indicate that we have officially launched the report, please. And somebody take a picture.
Why don't you also, because there's a lot of media outside, maybe they can come and when you know, this is another way also creating awareness.
I can see them moving. You better stop them.
To interview you.
Ah, okay, okay, okay.
One on one.
Yes.
Maybe I should call them so that I can.
Okay, 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 okay. People are tired and we need to close. And have we exhausted the way forward activities? For a start, how frequent are you going to meet? You talked about frequency and we haven't defined the frequency. Okay, okay, okay. The backbenchers? Any? Ah, okay.
Good afternoon.
Yes, in reference.
Yes, in addition,
Hey, what is that? Just talk. Oh,
in addition to that, we know that the most group who are affected with tobacco is youths. Sorry. In addition to that, we know most of the people who are affected with tobacco is youths, and most of the youths are found at schools. And from the schools is where they are just inherit those behavior from the actors. I mean, those musicians, what they see they're using now. What if we could initiate the clubs in the schools where we can reach those youths direct? Because I'm a teacher by profession. At school there, we have different clubs. There's the PCCB clubs, Mali High clubs who are dealing with the environments. What if we can initiate these clubs of Tanzania tobacco control at schools in such a way that we can have some representatives there at schools and we have different clubs and we can award them the certificates when they complete their studies. Now, this can help us to reach those youths in an easy way and we can give them the education on how to control the tobacco through their environments.
agreed, agreed. I think that's a good idea. Richard, you are the one who wanted the photo, so
To support him because in the past
supported.
we used to have a TTCF youth wing and it was very powerful. You know, you'd like to know because Tanzania has gone far down in terms of tobacco control. Even the donors have shied away. We used to mobilize. We had lots of youth. We had a special youth wing. So your point is very, very valid.
Yeah.
We need to work on that. Happy. Take it on board, please.
Well, I thought it is in the program they are making.
Yeah.
They mentioned about school and what have you.
Yeah,
It
we
should
need
be
to
taken on
organize
board.
the youth. Now, if we can please launch the report, the journalists that we're gonna save like placards. Please. Honorable. We indicate that we have Can you see or yeah.
So when I'm chairing. Okay. That's it. Yeah, we close first, then I will request you to. You first have to give a. What is coming first? Okay. Okay. Now. Huh?
I don't know.
No, I think you are to give the closing remark, then I close the meeting. Please, delegates, can we get seated? She's a delegate today. Huh? Huh? Okay, now we are inviting Professor Karim to give us a closing remark. Now that Kaushik is gonna, yeah?
It's fine.
No, you go there. Put on the speaker.
Hello?
Yes,
Good afternoon.
good afternoon.
I've been asked this afternoon to give a closing remark. And closing remark is usually something very easy because you consolidate all the presentations and then you say, good. But it can also be a very daunting task because you need to mention very key strategic issues on the way forward. So today we presented the Tobacco Interference Index report and launched this report for distributing it and spreading it, widespreading it to policymakers to see what's happening in our country. You know, in April 2007, the Framework Convention for Tobacco Control was launched globally, and Tanzania ratified and became a signatory to it in 2008 or 2009. It's already 18 years, and we are still in the red zone. It is possibly because of our own conflict of interest, lack of transparency, or business as usual. We don't know how to get this in a more meaningful way to help reduce tobacco sale and tobacco use. We also learned about the second-hand tobacco smoking, and we have not heard a little bit more about those other components of tobacco being used widely. I was actually amazed in a negative way, or you can say I was shocked. It's my third generation from Asia. So I'm as Tanzanian as anybody of you. being third generation, more than 120 years, my forefathers here, so can you imagine? So I grew up in a mixed community, the Asian, the Arab, the African, everyone. We lived in a very close community. There was Mzee Jumanne and Bibi Mariamu and all others. They were part of our community. And I had opened my eyes to see that the tobacco chewing, pariki, you know about pariki, was only confined to the Asian community. It was very Asian-oriented culture. But I am shocked beyond any words. If you come to Mataka Road here, Mataka Road, not very far from Muimbili, there are joints run by indigenous African population, and the customers are indigenous African population. This coping of culture of tobacco use is dangerous. Likewise, as you have seen shisha right in Arusha, in Masai land. It's really, the tobacco industry is working harder than what we are working. So as Mwalimu Baba wa Taifa said, as others walk, we have to run. I'm talking about Philip Morris. When I was a young O-level student at Rodani Secondary School way back in the early 70s, Philip Morris was actually taken out from our country because it was a Kaburu company from South Africa. And Mwalimu Nyerere abandoned them, they abolished them, they were sacked out. I'm actually, again, shocked to see that we are welcoming them with two hands. So the maadili yameanza kumongonyoka. And that is global in all the aspects. Global aspect, not global globe in Tanzania. Mwalimu Nyerere taught us, nitajielimisha kadiri ya uwezo wangu kwa ajili ya manufaa ya taifa. Now the maadili has changed. Nitajielimisha kadiri ya uwezo wa taifa ya kujielimisha mimi kwa manufaa yangu. Just the opposite. And now you can see that being reflected in the tobacco industry. We will do everything to protect our nation from any harm. But as long as you give me some kickbacks, I don't mind compromising the harm of my community. That's what's going on now. And it is very sad, actually, to see what we are doing in the tobacco family or in the tobacco, see advertisement, movies, all these dramas, the easy igizo. If somebody wants to look cool, he has to have a cigarette in his hand. He looks more cool, he looks more manly. These advertisements are distorting the minds of our youth. Access to cigarettes. You move around anywhere in Nazimoja, Kariako, anywhere in Dar es Salaam, anywhere. You find a Kitonga, that small little ungo, with pipi, cigarettes, and every kind of things. It's just being sold or in small boxes. And underage children are selling, and anybody can access it. It's the rule of do not sell it under 18, only it's on the writing there. But you can find everywhere on the street. You will find these boxes in Vitonga, Ungos, in Ekwa, anywhere on the street. You go to Kariako, the Machinga market, everywhere, You find tons of them on the street. So there is something seriously wrong with ourselves and our legislation and our regulations. Talking about TMDA, that's another ball game for another time. So in conclusion, the way forward which we discussed was to have a campaign which is more broader, to do strategic planning, to have presentations from all specialties. The ophthalmologist will tell you the effects of smoke on the eyes. The ENT will tell you that hearing and throat. The pulmonologist has told us already, the cardiologist. But the GI people will tell you about peptic ulcers and other issues, digestion and carcinoma of colon and others. The dermatology people will tell you. But the psychiatric on mental health will tell you. In a small study, we did elective study on depression among women. They said, I'm really depressed because my domestic life is in a mess. I can't fulfill my sexual life because the moment my husband comes near me, he is stinking. His mouth has a very bad smell. And I feel miserable to continue my life with him because he is a chain smoker. This is very subtle. It is not very well documented, but it is present. Have we more broader studies to see what is the mental health of a woman in her sexual relation or intimate relation with the husband in relation to smoking or perhaps alcohol as well? It has a very serious effect. Skin cancer, neurodevelopment, asthma, all those things. So we need more specialists to come and speak more about the effects of smoking. And smoking is satisfying to whoever is smoking. They tell you, oh, it's relaxing. But human being doesn't stop with relaxing on one issue. Once it reaches a certain threshold, then cigarette smoke no more relaxes him or her. Then you will go to a higher level. Then you might start taking cannabis. Then you might start taking cocaine. And therefore, smoking is an entry point towards all those other vices. Therefore, we need to do more studies about how Tanzania is collecting tax from minors who not only sell tobacco, but also consume tobacco and indirectly contribute to the tax. And all this need to be put into numbers because numbers are very important. And for that, we need to regroup and strategize. I'll finish here by these closing remarks and hand over to Professor Bingwa for closing. I am really honored and thank you very much for inviting me on behalf of Sir Francis Korea and the Pediatric Association of Tanzania.
Thank you, Professor Karim, for those closing remarks, and I'm sure various groups seated in here will take note of other studies that needed to be addressed to enrich the database on the adverse effects of tobacco use and smoking. Ladies and gentlemen, I think we have had a long day. You must be hypoglycemic now, exhausted, and it's time to call it a day. But before we do that, I need to take this opportunity to thank every one of you who has managed to find time to come and participate, contribute, and we appreciate your patience that you have stayed for so long. But that was not for nothing, it's for something to take us step forward so that when we come again next year or next 2 years, we will have moved 2 steps up, not 2 steps down, as the situation is. So thank you so much for all of you, and welcome back for another launch in 2 years' time. Is it every? Yeah, you will be meeting as specific groups, yes, but for the launch is in the next 2 years, okay? Those we have assigned them specific assignments, please take them off the ground and we'll keep track on what is going on, whether you've managed to meet you or managed to bring something new, or you've gone to sleep and we wake you up. You are all welcome and have a good day and enjoy yourself. Karibu. Oh. That is after closing though.